Welcome to the Pastore podcast. We are talking about the topic of the year, and that is the coronavirus and COVID-19. Now, Dr. Pastore, before we get into the questions today, I know that this topic is going to draw a lot of new listeners. So can you quickly go over your qualifications?
Oh, sure. Thank you. I guess I'll go in reverse where it's most important. I have a PhD in biomedical informatics, nanomedicine, and clinical informatics from Rutgers University School of Health Professions. My expertise is in the area of understanding biomedical sciences and all the different complex natures associated with that. I spent a lot of time studying human genetics, RNA theories, and identifying RNA substructures, disease processes and systems. And then, of course, everything to identifying nanomedicines, drug discovery and development. It's a pretty long description just for the PhD. Prior to that, I received my graduate education in human nutrition at Eastern Michigan University, where I, again, focused on a lot of genetic components, particularly for my disease. I have celiac disease, which is a food-based illness where I have an autoimmune disease caused by gluten, which are found in the dominant gluten-containing grains. I think everybody's probably familiar with those by now. And that culminated in my Master of Science in Human Nutrition. And in addition to that, I'm a certified nutrition specialist. Prior to that, in Albany, New York, I received my undergraduate degree in science. So I have a Bachelor of Science, which really started and was the fodder for all of this. I took every single science and mathematics class that was available. And as early as undergrad, I was taking very special specificity cases and classes in medicine, such as the microbiology of cancer or neurotoxins found in neurology, as opposed to, and in addition to just the basic courses that you would take as a pre-med.
And what you guys probably don't know is Dr. Pastore also has a photographic memory. So he is an absolute genius and he knows so much information just off the top of his head. He can close his eyes. A lot of times when we record these studies, he closes his eyes to think and picture the study and the title, and it just pops into his brain. So he is really one of the smartest people I have ever met in my life. I like to call him the real life house of the world, kind of solving those medical mysteries. He gets referrals from the Mayo Clinic, from top physicians across North America that don't know what's wrong with a patient. They run all the tests they know, and they send him or them to Dr. Pastore, and he's the one that cracks the case. So you are in good hands here, and all of the information today is backed by nothing but science.
I don't even know what to say. Okay, thank you.
That's also too really kind. Humble.
Could we state none of that was planned at all, and I had no idea that was happening, and that was a complete surprise? That's very kind of you to say. I appreciate that. None of it's true, but I appreciate it. Thank you.
All true. Okay, so let's get into the topic today, because it's literally what's going on across the world right now. People are in lockdown. Here in Toronto, we're on lockdown until at least the end of June. You're out in California. I know you guys have to wear masks whenever you leave the house. So what is the coronavirus and COVID-19? And I know a lot of people right now are comparing it to SARS about a decade ago. I was really too young to understand what SARS was, but how does that compare to?
That's a great opening question. So first, let's peel the layers here. The coronavirus is actually just a type of virus, and I'd like to just discuss what it looks like, because I think that'll help our listeners understand the name. And that's actually something I haven't heard in any of the sound bites on CNN or any of the coverage channels that anybody's watching. So under a really powerful microscope, when I was looking at this virus in university environment, it was so cool to see that they have such a weird pointed structure all around it, like surrounding them, as if they were had a corona or a crown on them. So that's kind of where this name came from. They just look as nasty as they are infecting things. But what we should also know is we've been exposed to coronavirus for a long time. There's so many types of these viruses, and that's your cold. So when you have a cold or you have a mild upper respiratory tract infection, that's a type of a coronavirus. And they're really mild type viruses that our bodies fight back. As we know, there's no treatment or cure, I should say cure for the common cold. These are really very evasive, intelligent viruses. They trick the body in a very effective way. And there's so many different types of them that if we were to develop a treatment, trust me, there's like 200 different types of the viruses that can cause the cold plus. However, there are types that can cause some real nasty, stronger symptoms. And that's what you started mentioning, Lexi, and that was very astute of you, is SARS. And I'll mention that in just a second, because I also don't want to forget Middle East respiratory syndrome, which was another type of a condition caused by a novel coronavirus at the time.
Now, what does novel mean?
So great. Awesome. So what's happening right now is a newly identified coronavirus type was believed to have come out of Wuhan, China. And that's what novel means. This brand new, heretofore human beings have never been exposed to it. And that is very challenging because we do not build up or have any resistance against it. Our bodies would not innately understand how to combat it. And that's what's really resulting in part of the problems. It gets a little bit more complicated, and I promise I'll be simple today, but I want to make sure I do cover the governing themes and the topics about this awful virus. But how it's linked to SARS, and you were really very dead on. There was a bad outbreak, if anyone remembers, from 2003 to 2004 of SARS, and SARS is known as a severe acute respiratory syndrome. That was caused by another coronavirus that you probably guessed at the time of 2003, that was novel, that was new. No one saw this before. Interestingly, it also seems everything is suspect. So you're going to see me very cautious with my language. SARS was one of the species of viruses that jumped from the animal kingdom into humans. And that's what we believe at this moment in time transpired with this novel, brand new coronavirus that is behind this current respiratory outbreak known as COVID-19. So please let me make it clear. COVID-19 is the infection, upper respiratory tract infection, and full body infection that's caused by this coronavirus. So it's important to understand that. So
it's a virus and an infection.
Bingo. Yeah, you can be exposed to the coronavirus. You can actually be a carrier of the coronavirus. You could potentially exhibit no symptoms and then give this virus, transmit this virus to someone else, and they could develop full-blown severe category COVID-19 symptoms. But now, if I could finalize the comparison between SARS and this, which I think is so important for us to understand in science and medicine, is that so far what we are learning about this coronavirus causing COVID-19 is that this infection seems to be spreading faster than SARS. So that's very important to understand. And I think one of the big pieces that I gave away, and I'll talk a little bit more about that today, are individuals that do not present with symptoms and can spread this, and then the individual can receive this infection, turn it into a full-blown condition, and end up, and I'm sorry to say it, but it's the facts we're seeing on the news every night, pass away from it. So one person can harbor no symptoms and then give it to someone else. This is a classic example of why we need all hands on deck and herd immunity and everybody working in concert as if they actually had the infection. We're still early in the research process, but I do want to state as the last note on compared to SARS, while it's spreading faster, at this moment in time, it seems to be less severe of an illness in the majority of those infected when compared to SARS. It's just a real tricky bugger trying to figure this one out.
So hypothetically, if I were a carrier and I passed on the virus to someone else, they got infected, but I never showed symptoms because my immune system is stronger, can I fight the virus but still pass it on and never get COVID?
Yes. Yes. And that's really just one component that makes this such a frightening virus. And I'm trying to keep emotion away. How can you not have emotion, right? I'm someone who loves people. So it's hard to, I have colleagues that just approach the scientific bench and they remove emotion. right? And it's so hard to do. So it's emotional because there's people that don't even understand that they basically are the weapon that is going into a large environment, and they may have incredibly strong, super healthy immune systems, and maybe they're just presenting with the tiniest cold and flu symptoms, maybe nothing at all, but they are passing it on to others. I would also like to say there's a second subset, Lexi. There's individuals that don't feel sick while they have the coronavirus in them, and then they're exposed to others. They get other people sick, and then further on down the line, they end up getting the full-blown COVID-19 symptoms. And that's also frightening because you never know. You don't know when to have that self-control until, of course, governors state by state started stepping in and putting on the brakes on a lot of the activities we were doing that were putting us into just massive social proximity that is normal life in our population these days.
And you said that so far COVID-19 hasn't been as severe as SARS, but what makes it so dangerous? Like, why is the world on lockdown now? Never before have we not been able to travel, not been able to leave our houses. What's making the governments put up all these regulations?
What I'll tell you, there's three things, and I know I already gave one of them away, so I'll save that for the last. Primarily, number one is the fact that it seems to be spreading faster than anything we've ever seen before. That's problem number one. Problem number two is that when it does kill, and we all know that it is taking lives on a daily basis, and we're seeing those numbers, and it's not even worth me saying numbers because it's so sad to say this, they're going to change by a very large number within 24 hours of this recording. And that's just a terrible statement, which of course you could, just saying that explains why the states have been acting and our mutual countries have been so aggressive to try to control this. But it really is in the individuals who have passed, all have experienced something very similar, which we call in biomedicine a cytokine storm. If I may explain that a little bit. So the term cytokine, it encompasses this multifactorial hyperinflammatory process where there's an increased expression of a type of pro-inflammatory chemical in the body known as interleukins. And then there's these other chemicals that show up, and those are called chemokines. And then yet there's another one called granulocyte colony stimulating factors. And all of these guys work together to then stimulate more immune system factors known as tumor necrosis factor alpha 1. And what does this all mean? It's just a really bad riot happened in a small venue, which is our lungs. And it causes this massive shutdown of how we process breathing. Just the normal process of inhalation and exhalation is completely taxed. And that is really
videos of that on the media too, of people in hospitals gasping for air, even on with oxygen and ventilators, they can barely breathe.
They can barely breathe. And it's really at this moment in time, and I can tell you because of my training and my background, and we could pepper it in if it's interesting for our listeners, where my efforts lie here. I'm not just reporting this information. I'm definitely active in this area using my skill set and what I can do to do everything I can to help. So yes, I too have unfortunately seen those images on the news and have had patients in my own practice who have had it. And a couple of theories that I know will end up being correct right now, and this I think is the first time it is being spoken in any form of media, is definitely the fact that there's a genetic genotype differences in a specific gene known as ACE2. And it is my humble opinion that individuals with an incorrect genotype of ACE2 that have a different type of receptor will allow this virus to get deeper set into their lungs, which then gives them a greater chance, probably with 100% certainty, of developing this aforementioned cytokine storm, which really shuts down how lungs work. And it's why you're seeing these horror stories of a 30-year-old with no pre-existing symptoms. By the way, I'm giving an actual story from CNN. A 30-year-old school teacher, male, no pre-existing conditions, pretty fit, coached the baseball team, was an all-star baseball athlete in high school, and is a teacher, and passed in a very short period of time, even went to the hospital for treatment and was sent back home to just recover in the privacy of his own home because it's actually a cleaner environment. And passed in a short period of time, rest his soul, because it did exactly what I'm saying. It upregulated to this point of a cytokine storm where by the time you could even address the breathing abnormality, it was too late. You'd have to be immediately there within an extremely short period of time to intubate the individual. And we can go more into detail of those things if you'd like, to then put them on a machine that breathes for them, known as a ventilator. And as you probably could imagine, you can't be awake for that. So you basically have to be in a coma. Your body would freak out. It would never allow that process to happen. I feel blessed in my own medical history to never had to go that path. But I could tell you, having my stomach pumped by them inserting a tube through my nose that I had to swallow into my belly was nothing. People probably laugh that off in our listening audience right now, but that was extremely traumatic experience for me, experiencing at 8, 9, and 10. I had it 3 times associated with my undiagnosed celiac disease. And that's just the second point that makes it so frightening. So just to recap.
People that have listened to our podcast previously, we talk about polymorphisms in genes. So
yes.
alterations or quote unquote errors in your genetic code that make that gene, I think you said it was ACE2?
Yeah, it's ACE2, yeah.
So it makes that gene slightly different than the general population and what it should be. And those that have that genetic quote unquote error are more likely to develop severe cases of COVID.
Yeah, that's really that's my humble opinion and my theory that I really believe will be proven. And it's really just something that it's just logical to me based on my training, that there's this polymorphism and an expression of the gene that's just allowing a greater receptor adherence for the virus to kind of take over. So yeah, that's really my humble opinion regarding the ACE2 component. And I have other opinions that I think will shake out as we have this discussion today that I think are active, and I am doing things about them, and I'm not just, talking to the corner of the room. I'm expressing it to the powers that be so that we can get work done in those areas. But I want to mention the third thing. So we said the first one was really the rate of spread is the fastest we've seen, and it beat that of SARS of 2003 to 2004. And then there was the aforementioned cytokine storm, which is horrendous and can shut down the lungs and people are passing away. And then the third one was the one I kind of gave away that, again, I really hate giving a number because it's going to change, Lexi. So don't hold me to this. But as of April 9th, 2020, about 25% of people can walk around asymptomatic. They have no symptoms. That's what the data says. And just to show you how that number changed so rapidly, and I'm not being dramatic, the National Library of Medicine reported on March 20th that it was 17.3%. And now here I am, not even a month later, and I'm there. No, that number's now 25. And I'm so afraid, and what frightens me, that I'm going to start hearing numbers that are closer to the 40s. And then you have a real, unbelievable, very difficult to control problem, because then you also have individual will to try to control. And you want to try to get very healthy people who are all sharing their madness and cabin fever on social media to understand they need to behave as if they have the infection. And that's what helps us flatten the curve.
So with people that are walking around that might have symptoms, we know the common ones of like cough and fever, but there are a ton of rarer symptoms or ones that aren't in the media. If I go to canada.com or .ca right now and look up COVID symptoms, it's cough, fever, take this test. We'll tell you if you should go to the emerge or not. But what else should people be looking out for?
I think I might shock some people, okay? But I promise you, and thank you for that. Well, I'm embarrassed by the opening, but thank you for the one statement that said everything you're going to hear today is based on solid science. That made me really happy, because I promise you it is. So I'm going to give you numbers, because I want to see this number looked at, and I want attention to go towards it. Are you ready? Here we go. About 3% of individuals with the coronavirus that are carriers, that think they may be asymptomatic, they actually have pink eye.
Oh.
And that could be the only symptom. Yeah. So I'm telling you, that's never been reported yet in the news and in the media. And if I'm correct, it's breaking here first. So pink eye is definitely something that you will see in about 3% of the cases. And we need to record these things because it's a great way to also try to identify this. And guess how itchy your eyes are when you have pink eye. Pink eye is basically conjunctivitis. It's an infection of the conjunctiva caused by a virus. And the coronavirus absolutely is one of the strains of viruses, plural, that can cause that type of eye infection. And you want to rub your eyes out of your head. It's highly contagious. It's highly spreadable. And you're touching your eyes.
So
you're definitely
is the coronavirus, not COVID-19 yet?
Correct. That's the coronavirus. And we're going to call that a potential symptom of COVID-19. So you could start leaning towards really bad COVID-19 symptoms and have this full-blown pink eye infection. Another one, and I did hear this once, but I don't think there's enough attention to it, is diarrhea and other gastrointestinal complaints. It's important to note, you can have the coronavirus and it can start infecting your gastrointestinal tract. It can behave in nasty ways there. And you may only present with those symptoms and think, I ate something bad, I had a bad salad, I had bad sushi. Yeah, it's exactly stomach bug. Correct, this is a stomach bug. And you're experiencing mild symptoms of this virus that depending on how bad that your gastrointestinal symptoms are, you should be reporting this to your primary care physician. Another one I'm hoping that has been mentioned, I did hear it only twice, was you could all of a sudden have a sudden loss of taste or smell. And some people have even missed that because they've been wisely following the rules and regulations by the Centers for Disease Control here in the United States and using diluted Clorox solution, and maybe they did not have an open room when they were making their own diluted version of that as instructions are given away, and they feel that they burnt out or numbed their sinuses. And then they say, well, that's why I can't smell that fresh orange. No, you're actually harboring this coronavirus, and it's what's truncating your ability to taste or smell. And then the last one on these little known symptoms is probably the most frightening, and that's into that same upper category of the cytokine storm, is you could all of a sudden have just confusion, sudden confusion. And right now we're connecting it to the potential of a reduced blood oxygen, but there's a possibility that there's more at bay and we don't know. That has to do with this confusion. So it is a symptom now that's being recorded. I am seeing universities report on this, and they're being more aggressive trying to tackle those main rare, if I should summarize them as four, I mean, I guess you could break apart the digestive symptoms to different types of ones, but for all intents and purposes, gastrointestinal symptoms. Those are the four hidden symptoms people may not know that they have this virus.
And for the more common ones like cough and fever, what is causing them when you develop COVID-19?
Yeah, so that's really your body's defense mechanism at bay. It's the virus interacting with your immune system. And you said the real common ones, right? We got chills and body aches, dry cough that you feel really deep down in your chest, not a tickle in your throat, something like you're barking deep down into your chest. And then there's a fever and there's shortness of breath, and you can have a headache and sore throat and congestion and fatigue. Those are massive immunological reactions. That's that cytokine storm starting. That's bringing in the guards and all the armory of your known immune system, your innate immune system response to defend you. And that's driving these symptoms. At the same time, you're having the replication of the virus. And that replication of the virus and how viruses work, and I think everybody knows that, is their RNA strands that fool your cells to reproducing themselves. There's not like just millions of them just taking over your body. They're inside you, making you photocopy them.
Interesting. I didn't know that.
And then they bust out of your cells. And then they go into the next healthy cell and take that sucker over and bust out of that cell, causing.
So it's kind of like if an army was taking over another army, but taking the soldiers of the opposite and switching them onto their team.
Correct.
Moving forward. Correct.
And that's really what this is doing. And that's what that RNA transcriptase mechanism is. RNA is then sent in and shuttled in to actually produce and photocopy, have your cell produce that virus. That's the blueprint, so to speak, in the master working of the nucleus of the cell that it's attacking. So the culmination of both events, the replication and your innate immune system response, result in that list of symptoms, and definitely in the primary main three given by both of our countries, right? We're all sticking with fever, cough, shortness of breath. And I think that's great. And I love our respective organizations, and I think they're doing a phenomenal job as aggressively as they can. But let's not forget some of the things I'm talking about today, and maybe calling one of your loved ones and having a FaceTime with them and really looking in their eyes and looking for pink eye and asking them some of those symptoms so that you could properly help us stop the spread of this. So one of the main things the CDC is saying that we want to make sure our listeners know is to immediately notify your primary care physician or seek immediate emergency help if there's trouble breathing, persistent pain, or pressure in the chest. There's any confusion. If you have a loved one that you can't wake up and you feel like they got bluish face or lips, that's really this COVID-19 fully taken over in the whole cytokine storm, shutting down their own respiration, and they need immediate ventilator help for breathing. They need to be put on a respirator. Please be aware of those signs and symptoms, and of course record those and do everything that your states are saying.
So how long would it take if I walk around with the coronavirus for it to develop into COVID-19 and then for me to start seeing those symptoms?
With the data we have now, and I think that's going to change, because I am getting some outliers, but the data right now is 2 to 14 days from time of exposure. So a healthy person holding onto this virus, they either develop symptoms later on or not. They can give it to me and I can develop symptoms within 2 to 14 days. What we are seeing, there's a cardiologist in New York that reported day 23 of symptoms and infection. So there was no classic, she did get the infection almost right away, but then was told I'll be fine in 14 days and ended up still being positive and sick on day 23. There are some people that claimed they were completely locked down appropriately and felt that they got sick almost a month after they were exposed to others that may have been at risk. But, it's so hard, Lexi, because if you think about it, and I don't want to drive people crazy, but it's like the smallest little details, right? We're learning how long it can live on certain surfaces, and 3 days on stainless steel and 24 hours on your delivery box that came to your door, and how long on a mailbox was the mail person sick, all those little details. And yes, I did completely disinfect my mailbox and everything else you could think of. And we'll talk a little bit about the day too. But yes, to answer your question, 2 to 14 days right now is the general rule, but I think we're going to find outliers outside that.
So you mentioned a little bit earlier that those that have the ACE2 polymorphism are more at risk of developing severe complications of COVID-19.
Yes.
But who else has to look out for being really cautious and really staying in their house, sending other people out to get groceries for them?
That's a great question, and I want to be as inclusive as possible. So specifically what we know right now, I'll name some general conditions we know for a fact by hitting check boxes and reporting that information to the CDC. And that is diabetes, heart disease, lung diseases, those types of pre-existing conditions. And then unfortunately, there's this superset term that really goes into a long category. And those are any immunocompromised individuals that are actively fighting HIV, individuals that could have an autoimmune disease and maybe it's not fully under control, those who have not yet been diagnosed with celiac disease, that may have been presenting at their doctor's office with what looks like a compromised immune system in standard laboratory testing. You and I did a whole podcast talking about what I'm talking about now, and if I could just very, very short soundbite it, but there's a 15-fold increase in a suppressed immune section of the population of celiac disease patients that is known as secretory immunoglobulin IgA. It is an antibody in the gastrointestinal tract and of course throughout the body, but primarily in the gastrointestinal tract that's really important to protect us from things like foodborne illnesses. And it's an awesome immune regulator. And people with my disease, sometimes when it goes too long without being diagnosed, they can be SIgA deficient. I've seen many cases in my career and I've come in to consult on many cases. And sadly, many doctors will think they're adroit in diagnosing celiac disease, and the type of antibody they would run would be IgA dependent. And drives you crazy. So someone could have tissue transglutaminase IgA antibodies run on them, but they don't have IgA to begin with. That was a wrong test to run. And I won't bore you because we have a podcast and a blog article on it, and we can direct you to that later if you're interested. But just to shut down that soundbite, individuals that are newly diagnosed immediately with celiac disease or have yet to been diagnosed are at a higher risk, any immunocompromised condition.
So let's talk about the recovery. There are some
Yeah.
people that say, it's 3 days. It felt like the worst flu I've ever had, and then I got over
Hmm.
it. And then we have hundreds of thousands of people that are flocking to the hospitals and
Yes.
thousands of people, unfortunately, passing away from this. So, why is the scale so large?
Yeah, and I'm going to add another. So I'm going to tie in some of the things we've been discussing, and it's a dynamite question to help me tie some of these thoughts together and make them more succinct for our listeners. The first thing is, and please let me preface by saying I can't answer this with 100% accuracy right now. We're going to know a lot more as we get further out. And I promise you, I'm pretty much in the thick of some certain areas of very modern research. And we'll talk about some of that today. But first, it's the aforementioned potential genetic difference in the ACE2 gene that can make it easier for the virus to affect a cell. And there could be people that also have a better polymorphism of that, Lexi, that makes it more difficult for the virus to get in their cell. How about that? Let's look at the glass as half full. You could have a polymorphism of ACE2 that makes the virus just more difficult to get in there. So that's pretty awesome. Then there's the aforementioned pre-existing conditions that complicate matters. And sadly, there are some people that don't take care of themselves. And there have been some reports that have come on my desk where patient X shows up to the emergency room and they were informed, not only do you have COVID-19, Mr. Jones, fake name, did you know you were type 2 diabetic? So that's like a huge bummer, that there's these pre-existing conditions that are not even known, and they come out when patients are entering the emergency room and they're identifying these things, because not everybody sees their doctor regularly. Hopefully this is a wake-up call for that. Here's a new thing we didn't talk about yet. We produce a chemical called a surfactant. Any chemistry fans out there, or any people who are as nuts as I was at 5 years old reading the back of a shampoo label and trying to find the surfactants that make the foam work? I was a very weird kid. We produce a surfactant chemical, all of us do, that actually make our lungs soft and pliable and make them like a sponge. And some of us don't make that much surfactant, and that's a different type of genetic polymorphism. So if individuals have less surfactants and they get a viral infection as nasty as a coronavirus that can cause COVID-19, it makes it much more harder for them to breathe than maybe their identical twin that has more surfactant production and has much more pliable, softer lungs. They're going to have, unfortunately, saying this sentence, a greater survival rate. And the aforementioned individual with this less surfactant production are typically those that reach the ventilator state.
So, what can we all do right now to safeguard against COVID-19 and flatten this curve? Because every single day that I watch these numbers, they keep going up and up and up exponentially, and it's going to be a while.
It's going to be a while. Yeah, it's going to be a while. There's some things that we don't fully know yet, like temperature changes and the virus. And I'm seeing two different sets of data, and it's way too early right now, particularly even in both our countries, and even me talking to you from Southern California, to say that temperature is going to matter. And I have family in Arizona, and I know some researchers in Arizona. So again, we still don't know, and you are correct. I think this is going to be a while. So what we want to do is we want to pretend we all have it. I'm sorry to say that. So that's a great way to start this. And I do have some points, and I think it's like 7 or 8. I have them loosely in my brain, but they're going to make sense. So covering the basic stuff from the CDC, and I can tell you what I report to my patients in writing is social distancing is actually urgent right now. I know this is a holiday weekend. There's Passover, there's Easter. There's so much stuff going on. Do everything virtually. Do everything with your loved ones instead of traveling to them. Make it a Zoom event or whatever, FaceTime, any type of picture event so you can still see and be with them and love them. And hopefully you can get more quality of those relationships, but practice social distancing. Wash your hands, but really wash your hands. Pardon me for this, but having that biomedicine background, when you squirt a little bit of soap on your hands and you quickly rub your hands under the faucet, that's not washing your hands. That's playing a game like a toddler would with a sprinkler, or a dog gets excited that they see a hose running. That is not washing your hands. You need to really get down and dirty and get the temperature that's comfortable for you, lather your hands really well, and sing happy birthday twice to yourself at a normal rhythm that you would at a friend's party.
Now, what is your thoughts on soap compared to hand sanitizer?
Both will actually work really well. It's the duration. Soap works quicker. Soap will work quicker because you're actually in a 20-second process. And all the data we're looking at is you're clean and you no longer would have coronavirus on your hands if you're washing your hands for a proper period of time, which is approximately 20 seconds. If you were to use hand sanitizer, which is one of my recommendations, if you can't wash your hands, use hand sanitizer, please make sure it's 60% alcohol. I'm not trying to be flippant when I say this. I'm not trying to be funny or in jest. So please pardon me that I'm going to be so direct, and I hope I don't come across as crass. But this is not the time to use the herbal hand sanitizer you bought at a holistic spa. I don't want you using lavender and sage and thyme hand sanitizer with like no alcohol in it, because that's not approved to kill any novel / emerging virus. That's a very important sentence that I will promise you I will cover and make sure you'll have links with regard to what supplies to use at your house. Stay at home as much as possible. I know that goes across with social distancing, but that's not true. Social distancing, by definition, is we should be at least 6 feet apart from an individual. I did look at, by the way, JAMA studies, Journal of the American Medical Association studies, of a coronavirus patient sneeze outside of a room. That's an amazing thing they did in a black light environment. And they were like, oh my God, is 6 feet really enough? These little type of respiratory droplets that can stay suspended in the air, you can suck that into your own lungs by just communicating and breathing, and you could bring that into your body. And by the way, when our governors and our state representatives and our mutual countries are saying wear a mask, surprise, surprise, it's not for you, protect you from getting the virus. It's to protect the person you're exposed to from your virus getting into them. That's really all that's good that your homemade masks are doing. They are absolutely not protecting you from absorbing the virus or getting it into your body. So please don't have a false level of comfort by wearing a mask and going out to a rave, if those things still exist. I'm dating myself. Do everything.
The conversation that I had with a friend was, if you're wearing a mask and someone coughs on you that has the virus, and then you take that mask off and touch it, now it's on your fingers, and you're probably going to touch your clothing and then wash your hands, and then you're going to touch your clothing again. Yep. So it's best
100%.
To stay home and not expose yourself to it whatsoever.
Correct. And you I love what you just said, because the point I was just about to say was, don't touch your eyes, nose, or mouth with unwashed hands if you're at home or you're out. Okay. Because we don't know the transmission process in the house. You know, believe it or not, there's even thoughts that like the family dog runs out of the yard and goes to the neighbor who's infected, loves on the neighbor, kisses and hugs them and gets petted and a rub down, then runs into the house, and, you know, Junior's playing with the dog, and then Junior ends up having symptoms, but the whole family's been quarantined and can't figure it out. Please understand, I'm talking about real cases because I have active cases in my practice. And there are cases where people are completely vexed. The first call I got was me forcing the test because the individual was healthy as a horse, as they would say, and was working in Manhattan and blew out an office because didn't even have a clue they were sick until finally got to me. And the tiny little changes in detail of the symptomatology I discussed led me to believe this individual could be infected. And it ended up in us quarantining the rest of the family, and they have other family members, and they couldn't go back home when they were being forced to leave universities and had to end up in hotels. So it's so important to really track these things down. But here's why I'm talking about the face thing, because Lexi, I had a study. Yeah, you had to know that was coming. So I was thinking, I was like, what's the most awesome, coolest thing that I could think of that I remember? And there was a study that was done. It was in New South Wales School of Medicine. And the title was on face touching. It was like face touching and frequent implications for hygiene.
Yeah, and just what I said at the beginning with his photographic memory, he just closed his eyes and pulled that up off the top of his head.
Yeah. So anyway, what did we figure out? I'll never forget this number. So the med students who were taught how to be cautious about their cleanliness, they touch their face and a mucous membrane area of their face 23 times an hour. So it's like, you know, and these are well-educated, well-trained individuals. I mean, I can't even tell you how many times I've been at a Whole Foods market and the individual wants to give the person in front of me cash change before the virus outbreak and would proceed to lick their thumb to swipe off bills. And I'm like, do you even know how dirty money is? and then I don't know where your thumb has been and what's going on with your tongue. And then and I'm thinking of all this as I'm watching this. So I've always had those types of behavior mechanisms, but that's just fascinating. So if you think you're as clean as a trained medical student at New South Wales Medical School, you're probably touching your face as much as they were, if not more. So be really cognizant of that. Funny story, so that you all know it. I'm not just preaching here. I had to go out and I had all the protection on me. And the funniest joke the whole time was I couldn't understand why my face was so itchy. And I said, all I wanted to do was scratch and touch my face. And I knew it was completely psychological, because it's kind of like, don't look at the pink elephant in the room. Don't look at the pink elephant in the room, right? It was like, don't touch your face. Don't touch your face. But it's itching me. So I was doing all these crazy.
Now, like as you're talking about it, I'm like, whoa.
Yes. I think people thought I had like a facial tic or something like that. And God help those that do and suffer. I wasn't faking it. I just could not stop the itching. Cover your mouth and your nose and your face and wear a mask when you can, when you go outside. And here's one of the big ones too, Lexi. I actually, through my niece, God love her, who was on my side, we had an argument with some of her college friends through her. I wouldn't stoop to those levels with the following. You need to clean and disinfect all surfaces that are suspect. You came in from the grocery store, you did something, you put something on the counter, clean that really well. And you want to use household cleaners. By the way, I talked about hand sanitizers requiring a 6% alcohol. If you're using alcohol-based surface cleaners, they have to be 70%, or they're not going to work. So you need to know that. But hopefully, and I promise you, I have the link. I won't forget it. I'm sharing it with all my patients. There's an EPA.gov link of all the approved products that can be used for disinfecting households that are approved and registered by the FDA through the CDC for new and emerging viruses. This is what's being tested in the laboratory to kill these types of nasty bugs. And they all have some type of chemical in them. When used appropriately, are completely safe. And the brands Clorox and the brands Lysol, which I know everybody listening either hoarded and got them all because you can't buy them anymore. Those are really the most appropriate substances to use at this time. You know, I don't care if I'm attacked for saying a fact. I'm not going to pour lavender all over my kitchen counter and expect it to kill this emerging viral pathogen, right? And newer ones that could come. We want to use the real stuff that will actually take care of this. And if you're concerned, you can clean it.
Clothing. So let's say you're going out to the grocery store. When you get home, I know I've seen pictures and posts of nurses that are coming home that strip off all their clothing before they even go into the house. Should everyone be kind of following similar practices, that as soon as they come in, strip off everything, wash it in hot water?
Well, that's actually a really smart thing. And we're going to have a link to the show, and I have it all ready and dialed up because I share with my patients on a daily basis, and it's preventing getting sick and cleaning and disinfecting CDC guidelines at this moment. And what's neat about the link I'm going to give you, it's going to change as we learn more information. And I say that because you all might know, if you ever listen to the nightly news that covers the CDC, you definitely would know there was no recommendation to wear any type of face protection for an extended period of time. And then the data came in and they went, whoa, now we're adding face protection. So at this moment in time, we know the following. If you work in a situation where you're caring for an individual that has COVID-19 and you're going into a residence to be with loved ones who don't, you need to strip down the clothes that you're wearing outside of the environment of the home where you're going to be with your loved ones. And you need to go take a shower in warm, comfortable water, not ice cold water. And you want to wash clothes appropriately, and hopefully you're wearing attire that can be washed in hot water. This isn't a time to have dry clean only stuff on. If not, throw it out, sorry, or just leave it in a garage for a week. We want to know more, right? I know all the data on this and the cloth and the 3 days, where there's going to be outliers. So that's what we really need to learn about all this, is we're going to definitely find out the outliers, and they're going to end up being subjects of documentaries and TV shows and of course the nightly news. So you want to make sure you do that. If you're going out to the grocery store and you're protected fully and you're trying to load up with various goods in your arms and you're holding, and you're wearing a sweatshirt and you're holding like tons of toilet paper if you're lucky enough, but just other items, and then you're putting them in your cart, and then you're going back to the car, and then you're coming into the house and you're repeating that process, disinfect everything you got, discard the bags, wipe everything down with a Clorox wipe or one of those types of disinfectant wipes that are approved by the FDA and CDC. And again, you'll have that list. And this is what I just did this morning with our bi-weekly trip. We're trying to stay home, but we also need to feed our daughter, and we all want to eat healthy. So we try to go once every 2 weeks and get it done as quickly and as safely as possible. Disinfect everything and basically boil your clothes in hot water. And I'm kidding. Really wash them as quickly as possible in your washer with proper detergent and then shower. I know it's crazy, but this is what we need to do. It sounds crazy, but I'm watching this spread on a real-time basis, and that's what's even more crazy.
And the final question that I'm sure everyone is asking is, how do we treat COVID-19? And will there be a vaccine coming out? What does the future look like for this infection and this virus right now?
Yeah, and this is, I'm sorry that a lot of my statements are always prefaced by saying, let's not say this is 100% accurate because we're learning new stuff. So please let me be clear. This is a real fast moving target, Lexi, and this could change. And I hope it will change right away. So sadly, at this exact moment in time, April 9th, there is no FDA approved, CDC approved, NIH or WHO approved, and that's referring to World Health Organization, approved medical treatment for COVID-19. What we are practicing in a hospital environment is palliative care, care for symptoms. There's some experimental treatments of medications that have already been approved in certain areas, and I'd like to talk about some of that today and some trials that are going on today, but I also want to provide hope. Please know there's a lot of intelligent people that are involved in this process. This is multiple countries and universities all working in concert. There's what's on my desk. How about a list of 60 trials planned, recruiting, or underway? So that's what I have. And I was literally updated just this morning around 8 a.m. of day 6 for a trial that's being recruited at NYU. It started on April 2nd. For HBOT, hyperbaric oxygen therapy for COVID-19 respiratory patients.
And
it's
what
a form
does
of therapy.
that mean?
Yeah, it's a form of therapy. It's putting patients in a higher, pure, rich oxygen environment. It's been used in a hospital environment to treat lung damaged fire people, men and women of our fire departments. It's a great way to help get them recovered quickly when they have any type of damage from inhalation of smokes or caustic chemicals. They run into various industrial environments and they can harm their lungs internally. It's been found to be something that could be beneficial. But having said that, and the only reason I led there was because that was the most recent study. I wanted people to know that there's some really strong stuff that's going on that's exciting. So the first thing is I want to mention this category. It's known as repurposing, reuse. So there are approved drugs by the FDA, and right now everybody, all science groups are looking at what can we tap into in prior medicine that we could repurpose as small drugs to treat COVID-19. Small drugs meaning they have a very specific unified target that we believe could be antagonistic to the spread of the coronavirus, just thus slowing down the spread so we can allow other therapies and the human immune system to get a fighting chance.
So when we talked about the RNA and like the armies attacking the opposite people and switching them over to the side, it's slowing that takeover.
Correct. It's slower. It's slowing the takeover so that you can actually have a fighting chance. And that's really the best form of medicine. And that's really how the majority of antibiotics work. I don't know if anybody, that's basic medical school is an antibiotic that you're given for an infection doesn't 100% annihilate all of the bacteria that's being targeted. It knocks it down to a level where your immune system can kick its butt. And that's how the immune system should work. And that gives you some memory, nothing like a vaccine, of course. And I'll talk about vaccines, of course. But I just wanted people to know that this is really exciting that we're finding some new drugs that are underway. There's one that's going on in Nebraska on an RNA polymerase inhibitor, and that's it's a drug that actually targets the way coronavirus would replicate. So that's awesome. Then there's binders that just kind of tie it up and chelate it. And there's a trial going on right now. And by the way, when I say there's a trial going on right now, I mean there's a trial going on right now on COVID patients. So I'm going to tell you where the drug is. And if you want to know the names, I can do that as well. But I thought it just made sense to give like a global view of these. Then there's another one, it's known as Camostat, and that's what's called a transmembrane protease serine 2 inhibitor. And that just again blocks penetration of coronavirus from even getting into a cell for the replication process it needs to do to survive. That's in trial right now. That's an oral medication. The two aforementioned ones that I started with are intravenous. There's another one that's in oral route that is a combination of two HIV medications. So that's one that can help tremendously. Probably one of the coolest things that's coming out right now is something called an immunomodulatory drug. It's known as sphingosine 1-phosphate receptor modulator. And that's one of the classifications of drugs that were being used for multiple sclerosis. So when you have an autoimmune disease, calming down some part of the immune system. And that also gives us clue as to why I said to our audience and to you that this cytokine storm is one of the most frightening components of this disease, tricking your own immune system to just go ballistic and start harming yourself to the point of shutting down your ability to breathe. And using some drugs that may calm that down can be extremely beneficial. Then there's another category that I'm extremely interested in, and that's in allowing the addressing of COVID-19 symptoms that would allow other medications to work more rapidly and safer. And then I'd be remiss if I didn't mention what's all over the news every night with some controversy is the drug trial that's on right now for Plaquenil, better known as hydroxychloroquine. And that's a drug that's used in lupus. It's an anti-malaria medication. It's always used in a combination with other drugs, typically azithromycin. It's being used for deep infections of the lung with a theory. I want to make it clear right now, there's no absolute 100% certainty of its efficacy. There's only rumor and anecdotal evidence, which I understand is an emergency. And I'm happy to report that my alma mater, one of them, Rutgers, is a rapid, right now it's way underway, a rapid examination over at Rutgers Cancer Institute in New Jersey, analyzing the efficacy of this drug in, by the way, Plaquenil, hydroxychloroquine, in combination with azithromycin on patients with COVID. I'm going to be looking into a rumor of a French study that was paused due to some cardiovascular abnormalities, but right now I want to look into it. The only thing I can state that's not a rumor is all medications have some side effects. So we really have to understand who our patient base is, and that's so critical. A bulk of my work in practice is something known as pharmacogenetics, where I'm called into a case to identify what drug could harm a person based on their unique genes. So a drug could be a lifesaver for one patient, and it could be actually a severe symptom producer. And by symptom, I mean side effect producer, if not really deleterious effect in another. And I'm called in very, very difficult, challenging cases. Like I recently solved the case of cyclical vomiting syndrome. And what broke the entire case was me doing a pharmacogenetic case on everything the individual was exposed to in the pharmacology class. And that helped me identify that individual. Interestingly enough.
Like the people that have the ACE2 genetic polymorphism that can either make COVID-19 worse or better.
Or better, yeah. Yeah.
People can also have genetic polymorphisms that make them react to specific medications that for most of the general population would work, but for them specifically, if they have this genetic error, can make things way worse.
Yes, and in this specific, in pharmacogenetics, you're looking at the liver processing specifically, and of course we can get more in depth, but just keeping it specific and basic, you're looking at how the pharmacokinetics, how the drug is utilized, absorbed, and excreted. So the excreted component is the liver, and there are specific enzymatic pathways of all pharmacology that go through the liver. And in these unique medication instances, when you're swallowing an oral medication and then it's processed and it's excreted and goes through the liver, it can in some patients build up into toxic levels. They need much lower of a dose. In some cases, it should be avoided strictly. In other cases, they're non-responders and they would need a higher dose. And you are correct, that's all based on their unique polymorphisms of how their gene is transcribing the usability of that enzyme system to process that medication. So it's just a great, incredible piece of information. And I keep adding as the data gets more and more and more powerful and accurate. And by the way, the accuracy of what I'm doing right now is 99.999%. And what's interesting is I'm up to 17 pages of a font of 8 of drugs that I can test for in different classifications. So I was able to identify a patient and call them and say, look, I know what you're hearing on the news. You are pharmacogenetically not able to process Plaquenil, hydroxychloroquine. You have the evidence on your desk. I talked to your physician about it. I just am reminding you, don't run out and take this as a prophylactic. You know, some people are hearing it in extremist media and they're running out and they're, you know, harboring it and seeing if they could just start it and take it. There was an unfortunate story as a couple in Arizona and a really dire circumstances of an individual mixing up the names of the medication. And the spouse, one of the partners of the couples that took it, actually ended up taking an antiparasitic for a koi pond. And it unfortunately, the husband passed away. That's a true story, by the way. That was amazing. I tracked it all the way down to fact.
So there are people out there right now that are taking drugs to prevent them from getting COVID-19, like not showing any signs, not any symptoms. Like it would be like taking an antibiotic for an infection when you didn't have the infection, right? Yes.
And Lexi, it's more frightening than that. There's medical doctors being fined for bulk prescribing in the United States. So there are doctors that heard a soundbite and they're running out. Now, please let me make this clear. I want every drug I'm talking about to work. I want all of them to work. So we have an abundance of options. There will be no one standard set treatment for this virus infection at this time and for the foreseeable future. There will be polypharmacy, which means multiple medications in different classifications to address multiple different things, interrupting the virus's replication, addressing a symptom set that's making breathing worse. And I'll pepper in some of the things that I'm working on now with this specific COVID-19 spawning throughout our mutual countries and the world. But there are people that are running out and taking these things where we don't have the data yet. You know what, for a scientist, everything is correlation and that's not causation. And nothing exists unless we have academic solid science that proves I understand we're at a rush, but we're at a rush to save lives. And let's say someone has a really bad prior history of arrhythmias, cardiovascular abnormalities, and then you put them on hydroxychloroquine with azithromycin, azithromax, or Z-Pak. Please understand the medical literature on that. Don't even believe me right now and hit pause if you're listening and then go to Google Scholar, nowhere else, or PubMed, and then look up the side effect profile of that combination of drugs, and you'll see an increased cardiovascular mortality if you have a dysrhythmia or some type of abnormal heart rhythm or heart problem. So you're immediately in this like gray area. Now imagine you're not in a medical environment and you hear a soundbite, but you do have one of these pre-existing conditions, and then you go and you take this as a prophylactic. That's a problem. So that to me is as urgent as me trying to, and my colleagues are trying to, in the world of scientists trying to fight against this viral infection. You want to save lives. So also misinformation can be as destructive and it can spread as quicker, if not quicker, than this virus we're discussing today. And that's definitely one of my concerns. But I do want everyone to know, to just be on a positive note in this last thought, and I'll mention a last sentence regarding myself. It's so important to understand that we have really super smart minds on this, looking at multiple areas of different drugs and how this virus works and how to shut it down and how to improve breathing. If we can track and identify our individuals as quickly as possible. Testing has been abysmal in the United States. Everyone's working as hard as they can. I spoke to a top researcher just yesterday afternoon out of the NIH. We're looking at, oh God, weeks, fingers crossed, may it be sooner, of a finger prick test that will be able to identify this virus with 100%, almost 100% certainty, at least over 95%.
Ooh, that was another question I wanted to ask you. With the testing that's going on right now, I'm reading a lot of things that it's not 100% accurate with the throat swabs.
Correct.
So what's the
we're looking at at max, where at the best I can see is 87.3%. And that sounds good, but imagine the false sense of security of that demographic. That's falsely negative.
If you have 100 people, 87 are like, yes, you have coronavirus. 13 are walking around saying, no, you're fine, go live your life. But they actually have it because of the false negative. And now they're going out to the grocery store. They're talking to their neighbors across the yard. Scary.
I always use this reference, and I don't know why I do, because I think my disease primarily has such devout European roots, and I'm referring to celiac disease, but I always bring up the soccer, the proper football stadium, right? Lexi, I always say that because they're massive. And I'm thinking of these 13 people with their face paint on walking into a Manchester United game against the French. And I'm thinking of this 60,000 people there and 13 people walk in. Can you imagine the effect of how many people they could infect? That's just unbelievable. So I'm saying the affect of the effect. Wow. It's really of the infect. It's really scary that could transpire. So yes, so that's a concern for me. It's a massive concern for me. And it's why so many doctors are frustrated, and I can't even tell you how many doctors I'm talking to that are on the front lines. And I'm from New York, as you know, and it's really weird circumstance of events that I left right as all this was transpiring and right before it exploded. I could assure you I would be really in the trenches. That's without a doubt, because I'm born and raised. But right now I'm where I am, and I'm doing what I can my way. And we have very strict rules in my new home state of California. And so vaccines. Tests are coming. They're going to be more accurate. Number two, vaccines. We're definitely over a year out, but the data is running, and there are trials going on right now. And we're looking at using plasma of those that were infected and have recovered 100%. So we have real awesome baselines that are they're giving us the ability to have just an awesome a fight and an awesome attack to go back. My colleagues and I recently are zoning in on a specific cell surface receptor that would actually suppress the cytokine storm. So we think we can actually trick the body to not freak out. And if you don't freak out with that cytokine storm, you're not going to go on the ventilator. You're not going to lose your breathing. You're not going to die. And we just bought a hell of a lot of time for you to then get the proper treatment. And one of these other medications would come in and be able to clobber it and stop its replication. And then if that transpires, and we're working, trust me, aggressively, as hard as we possibly can to get these trials going as quickly as possible. And this is an offshoot of my work with people from the NIH in the task force. So if we get that all done and that works, that will hopefully get us to the point of everybody's doing all the aforementioned things we talked about to flatten the curve so we have less infected, more time for us to come up with a really great standard treatment of care, and multiple of those, as I said, multiple drug options, multiple suppressing agents, hopefully the idea that I'm working on that can stop the actual storm behind the killing of people so that we can then attack it, and then that would lead us up to a vaccination. And when we get to that point, then we would have what's known as herd immunity, and then we have to get through all the red tape of making sure everybody gets it. And then you could bet this, Lexi, if I could add one last thing, I will be following up on the celiac disease community to make sure that they are responders. That is my personal private vow. I'll be starting it within my practice. And if you want to know how I will do that by the same mechanism one would test a vaccine. When the vaccine's out and approved and administered, I will be testing the antibody response in the celiac disease population in addition to the others that receive it, and then look for a difference.
Because as we covered in previous episodes, celiac disease patients, whether they are gluten-free or not, might not take to vaccines as well as the normal population would.
Yeah, and it's some like the hepatitis vaccine, for example, and there's a risk for pneumococcal infections in the celiac disease population, even though, like you said, they may be gluten-free. And it's things we're trying to figure out and learn, and we think it's a long-term potential epigenetic change of the immune system response, and I'm actually working on that now. I'm looking at genetic measurements of one's immunity over time, so I can capture those, and that becomes publishable data. And of course, I'll always share that, and I'm an advocate of patient care for the Celiac Disease Foundation. So I'm gonna do everything I can to accurately protect my own kind, in addition to as much as I can for mankind, if that makes sense. It's corny, sorry.
So to close this out, where do you see everything evolving, let's say in the next 6 months? How long are these clinical trials going to take before we get a definitive yes or no?
Yeah.
And do you see cases continuing to get worse for the next little bit?
I think for the next, these are really difficult questions. Boy, you got me sweating because when you said 6 months, I panicked because you see how quickly things are changing, right? Just on those walking around that were non-symptomatic went from 17.3% up to 25% in less than 30 days. So what am I hoping? So what I'm seeing and the reports that I received yesterday when I had that high level closed door meeting was as follows. If we could just keep doing what we're doing, we're starting to see those signs of flattening out the curve, which is really so important, which means less numbers is what I mean, less infected. And if we have less infected, it just gives us better reaction time. It frees up all the damage that's happening in our emergency rooms throughout all over the world. So bad in New York City right now, which is breaking my heart. And the aggressiveness in my new state of California has been so successful so far, knocking on wood, that our governor actually gave 500 ventilators to New York City. Which is remarkable because we were able to see our numbers were going down because everybody was just self-policing, being seriously militant, and doing everything they could. And I'm watching it controlled. I'm watching how slow the numbers are going. So what do I expect? I expect, like our CDC and our Surgeon General are saying, that this is our apex week. I'm hoping that this is it. And we're going to start to see a very slow decline. Everything will go faster the faster everyone's doing what the CDC is saying. I know people listening to this care about their health and they're probably doing it. I just want you to know that's not the case. I don't want to give anything away, but I'm just going to tell you it's not the case. I have a lot of friends and colleagues out there. I have spies out on boats sending me photographic images of beaches. I'm seeing that. So before things were closed, I have friends and colleagues saying, do you see this? And I'm seeing that data and reporting that data because it's absolutely urgent for us to do so, because this is how this is spread. And then what I'm hoping this will do is get to a moment of quiescence where things calm down a bit. We will have data from trials. Rutgers is really fast. They're an awesome pharma-based institute of research and design and development. And I'm expecting them to have solid data in months. I'm going to say that with an asterisk, that I'm hoping it'll be even shorter with what's transpiring with at least one drug over at Rutgers Cancer. So I'm thinking if we did this in less than 6 months, I'm thinking of a flattening of the curve, more movement on the vaccine front, and getting very close to at least presumptive, this is a good treatment plan for this category of patients. This is a good treatment plan for these others. And I'm hoping that we'll meet in the middle there, and that's what will happen over a 6-month period of time.
Let's hope so.
Yes.
So we are asking everyone listening to this podcast to do your part. Stay home. If you are going out, wear a mask to protect other people. Do everything that Dr. Pastore mentioned about how to prevent you from getting the virus as much as possible. Everything that was talked about today will be in the show notes, including those links. If you have questions or concerns, you can reach out to Dr. Pastore. His website is drrobertpastore.com and at Dr. Robert Pastore on social. As we get more information, he's going to be releasing more articles and blogs, and we'll probably do another podcast on this somewhere in the near future when more information comes out. But we are here for any questions that you have. And thank you for listening. Stay safe, stay inside, take care, and we hope to see you next week on the Pastore podcast.
Thank you for listening.